This is Tom Lee, Editor-in-Chief for NEJM Catalyst, and we're talking today with Andrew Masica. He's the SVP and Chief Medical Officer for Reliable Health under Texas Health Resources, a very large delivery system in Texas. And we're talking because I recently had a conversation with Andrew, and he had some really interesting insights into the evolving role of the Chief Medical Officer. And he brought up a model with 3 different types, which brought some interesting structure to something I'm very interested in, and to understand those models and how they fit with different types of healthcare organizations. We'll talk first about Andrew's work at Texas Health Resources and his organization and his current priorities, and then talk a little bit more about the model itself. So first, Andrew, not all of our listeners will know much about Texas Health Resources. Can you just describe your organization structurally for a few minutes?
Sure. So first off, thank you, Tom, and appreciate the opportunity to speak about this. So Texas Health Resources is a nonprofit, faith-based, integrated delivery organization in North Texas. The system includes over 350 points of care access, including 28 inpatient care facilities and 250 community access points. We also have more than 25,000 employees and 6,000 affiliated physicians on our medical staff, 1,000 of whom are in our employed physicians group.
So 1,000 employed physicians and 5,000 affiliate physicians who are not employed. I'm sure that's evolving, and maybe you can say a bit about Texas Health Resources' current top strategic priorities and how they've been evolving over the last decade.
Sure. So I think I'll touch on 2 points there. So the first is about 18 months ago, we had a structural realignment in our organization, and the intent there was really to become a more consumer-centric organization that provided care and services across a continuum. And the pillars of that organizational model, if you think of the consumer as being at the center of that, we moved to a platform of having channels. So channels are the interfaces where care is delivered. So there's a hospital channel, an ambulatory channel, a virtual care channel, just as examples of that. And then we also have, surrounding that, capabilities, which are how we conduct those interactions within the channels with the consumers. So my title is Chief Medical Officer of Reliable Health. Reliable Health is what drives quality, safety, and experience as a pathway to value within that new structure. So that's sort of the first point. The second point is our big picture strategic priorities are to move from being a single business unit that was focused on acute episodes of care to a more diverse ecosystem. So we've been evolving in that direction really for the past 5 to 6 years. But what that looks like is if you have a portfolio of what we would call traditional services, either based in the hospital or clinics. We're trying to expand the portfolios in 2 other areas. So the first are digital and retail offerings, other services that we would offer consumers, employers in our community that would promote health and wellness. And then the other portfolio has to do with an increasing activity in risk-based contracts and value-based care. So just in terms of where the overall healthcare market is heading, our structural realignment was designed to position us to compete in those spaces and grow our presence in those the more diverse set of portfolios. Within that, I would touch on four strategies that are top of mind. So the first is growth. The Dallas-Fort Worth area is a rapidly growing population center, and we want to make sure that we remain competitive in the market, and that the new individuals and the new population moving into the market that we're able to capture that and provide high quality services to them. The second strategic priority surrounds capacity and access to care. And this isn't the traditional model of capacity where it's just talking about building more hospital beds. This is really creating different access points, virtual access points, partnerships with community care locations, again, to be consistent with a continuum of services. The third would be strategic collaborations with different partners, both nationally and in the Dallas-Fort Worth community. I think the efficiencies of trying to build everything in-house, it's not necessarily something you want to do. So whether it be an academic partnership, a research partnership, or something with an employer, I think we're looking very closely at different innovative models that we can deploy there. And the final big bucket strategy is organizational agility and how do we maintain and support our workforce during trying times. So those are the four top-of-mind priorities at the organizational level.
Well, those are really interesting, and, I would say that when I came out of medical school and began my career a few decades ago, words like reliability and value weren't prominent on the minds of physician leaders. Growth certainly was the first of your four strategies, and improving access probably was, but strategic collaborations, having a more agile culture, trying to become highly reliable, trying to improve value, these were, no one was against those things, but I can't say that they were the focus. And so I'm not surprised, but I'm reassured to hear the clarity with which Texas Health Resources is thinking about what it needs to do. And its thinking probably has something to do with why they hired you, someone who is different from some of the traditional models of CMOs. Can you lay out for our listeners what you consider the two more traditional models of CMOs to be, and the third model, which I think you represent?
No, certainly, and really, I think these aren't mutually exclusive. But if you they're really different functions of the CMO role that need to be dialed down, up or down accordingly, sort of based on where organizational is, and also based on the context of specific events. So I think the sort of the first function, and where many of the CMO roles started, was more as a medical staff liaison in terms of physician engagement and alignment with the organization. If there were any sort of behavioral aspects that needed to be addressed, I think that was very much in the wheelhouse of the CMO. Over the past 10 to 15 years, there's been an increasing focus on quality and safety as being directly in the purview of the CMO, as what health systems are accountable for and what we're actually able to measure. As that has increased, I think that has become a critical component of day-to-day CMO activity. But given where the general market is headed towards a movement for value-based care, I think the next evolution of the CMO and the next function of the CMO position is really going to be promoting transformation and organizing around value. And the skills that one would need there are being comfortable with pushing innovation, having a degree of acumen with data and analytics, and really serving as a translator for data and analytics, and then the bottom line is comfort with being a change agent. These are not easy models to shift. They're well ingrained. So I think facilitating that transformation has been added to the CMO job set of responsibilities.
Well, the framework that you lay out, I actually think is a terrific one, and I've been testing it with other people I've talked to since we had our conversation, and they like it too. One person said to me, his framework brings order to what I've considered a chaotic career that I've been pursuing. I think of the first phase where you talk about relationships as one where, what you really needed to be a good chief medical officer was you needed the trust of your colleagues, that you could broker relationships and make sure that bad apples were in fact detected and good apples were in fact recognized. The second phase, I feel like, is pursuing high reliability. It took some understanding of systems to actually work to make care reliably safe, to pursue zero harm and analogous goals in other areas. But the third one, transformation of the organization into a strategic animal that can compete in the marketplace that really needs high-value care. That's something beyond high reliability. So how did you pick up the skills that enabled you to be a Type 2 and Type 3 CMO, at least in the hopes of Texas Health Resources?
So my first comment would be that those three functions that we just talked about, that those, I think it's not an either or, it's an additive type of relationship. So that even if you have been asked primarily to be or more focused on the transformation elements of being a CMO, the quality and safety and then the medical staff engagement is still part and parcel of what you're doing day to day. So I think of it more as additive rather than an either or. In terms of my own background and journey, early on when I considered a career in medicine, part of the appeal was that it allowed a number of different pathways, and there were a number of different skills and experiences that one could apply in a career as a physician, and I've found that to be very true. I still love clinical medicine. I've practiced as a hospitalist for more than 18 years, and that really provides a strong foundation for everything I do in the quality, care transformation, and research space. More specifically, I think there were a couple of events that helped prepare me for this particular track. So the first was after my internal medicine residency, I did a research fellowship and took a master's course and gained some skills in biostatistics, epidemiology, and study design, and translated that into a health services research track. Health services research, health system science, that type of research is very useful for helping to shape care delivery and being a facilitator for transformation, because that's, by the nature of what you're doing, your health services research is really focused on evaluation of care and care delivery models. So I think that was one element of it. The other element, as I mentioned, I've practiced as a hospitalist. You're right in the mix of frontline patient care, and so anything from implementation of EHRs to how a health system would deal with the different quality metrics that they're asked to report. You're living that day to day, and you really have an opportunity to see where the high yield care improvement efforts are available to act upon. And then lastly, I've been fortunate to be a part of forward-thinking organizations and had good mentoring, particularly in terms of people who gave me opportunities to lead different projects. So collectively, I think those were the factors that I feel prepared me to tackle this type of the third evolution of the CMO role.
Well, from our prior discussions, I would throw in there that before your medical education began, you majored in history, and you've got the big picture. And I think your ability to communicate, to write, and to speak clearly and well, and think clearly and well, are probably essential ingredients as well. But so how are the physicians and other leaders of Texas Health Resources responding to an agenda that really must still feel fairly new?
So, so far I've had a great experience with Texas Health Resources. I started about 2 weeks before the first cases of COVID-19 hit the DFW area, and if you think about from a big picture standpoint, if the push towards value-based care and there's differing rates depending on what part of the U.S. one lives in. But if that pathway was 5 to 7 years in the timeline, where we would have significant percentages of value-based care arrangements in place, I think what COVID has done is it sort of reset the market, and the time horizon now seems to be 2 to 3 years rather than that more extended time period. So with that, I think there's been a recognition from physicians, certainly in our market and also across the U.S., the interdependencies and how everything is connected between health systems and the medical staff. So I think that has really brought that to light and really creates sort of an imperative to move on this faster than we might have otherwise. Some specific examples where this new model seems to be moving forward at a good pace. The first would be in terms of the partnerships. We do have an affiliation agreement with the University of Texas Southwestern, and we've created a clinically integrated network called the Southwestern Health Resources. Southwestern Health Resources has been a top performer in the next generation ACO model in terms of Medicare savings. And so we feel that is going to be an outstanding platform to continue to push that movement towards value-based care. So early returns on that have been promising. We think there's a lot more we can do in that space. The second would be converting to more of what I would call a fully empowered clinical service line model. Clinical service lines as a way, really as an enterprise-level node to define best practice, to track quality and safety, and also to have a clinical voice in the strategy for really how to provide a set of services across the care continuum. And we're starting to make some headway moving from a conceptual model to that approach as being something that physicians really buy into. And unsolicited, I've had a number of physicians reach out to me and actively suggest and want to be a part of those service lines as we look at constructing those. And the last piece would be in the research and education space. As we look at our strategic collaborations across the Dallas-Fort Worth area, the interest in research and really being part of the learning health system model, where not only do you synthesize external evidence, but you generate new real-world evidence as part of day-to-day responsibilities in the healthcare system. There's been a lot of interest from physicians and from the organization recognizing our responsibility there. So that's very promising, and that's something that we want to grow our capacity in as well.
Well, thanks so much, Andrew. I have to say that your perspectives and the potential suggested by the kind of new models that you talk about are frankly really encouraging. They make me optimistic that we are going to move even faster toward a high-value healthcare system. And I know we'll be getting your insights along the way as NEJM Catalyst tries to share learnings from systems around the world with our colleagues. So thank you once again, and good luck with this work.
Tom, thank you very much. Appreciate the opportunity to talk.